3,
2,
1.
Good morning, everybody. My name is Jens Chapman. Welcome to this edition of STED Talks. It's December 18, 2024, and welcome to the Seattle Science Foundation. Today is a very special pre-holiday treat. We have Dr. Greg Mundis Jr. here, and I'll introduce him in greater detail later, but he's one of the preeminent spine deformity surgeons and spine surgeons in the world, and he's phoning in from San Diego. Again, a greater detailed description and introduction later. Today's topic is obviously going to be about spinal deformities, and the title STED Talk, Spine Technology Education, and the multidimensional D stands for today deformity, but also discussion, discourse, disagreements, debate is that certainly going to hold true today. As always, we have a couple of cases first to show, and maybe we'll start with Dr. Nick Minisali. Good morning, Dr. Mundis. Can you hear us? Can we have a...
Absolutely. Good morning. Thanks for having me. Can you guys see me okay and hear me okay?
Yes, loud and clear, and it's so great to have you here. I know you're super busy, so we really appreciate you. And just so you know that the other day somebody sent me a text, because we always get suggestions from our worldwide audience. Hey, can we have Dr. Mundis on? And like, as it so happens, this Wednesday will happen. So our colleague's wish came true. Dr. Minisali, without much further ado, show us a case that you recently were involved with, and let's hear what Dr. Mundis has to say.
Yeah, absolutely. Thank you so much.
So this is Dr. Nick Minisali, and he has a big smile on his face. He's from Philadelphia. He's from the Rothman empire over there, and his Eagles are doing quite well, so hence this.
Yeah, go Birds. So thank you so much. So I have no disclosures relevant to this talk. We'll start off with this patient who's a lower 50s-year-old male who presented with bilateral leg pain, low back pain, as well as left lower extremity weakness with a history of multiple prior spine surgeries. As far as medical history, pretty healthy gentleman, hypertension, had a sleeve gastrectomy. As far as surgical history, back in the late 90s at an outside hospital, underwent a T12 to L2 lateral fusion with a fairly large kind of shark bite surgical incision, and what seems like a partial corpectomy at L1 that is since fused, as well as a C4 to 6 ACDF at an outside hospital, L5 to S1 standalone ALIF with posterior decompression in 2021 at an outside hospital, and then subsequent L3-4 laminectomy and discectomy. And then most recently had a spinal cord stimulator placed in April of this year. Not a smoker, social alcohol use, BMI is 26. On exam has left hip flexor, quad, tibant, and EHL weakness, but all 4 out of 5. No long track signs, some mild decreased sensation in bilateral lower extremities. A prior outside EMG showed no polyneuropathy or anything like that, some just long-standing radiculopathy. So here are his films, standing scoliosis films, and I have our parameters here. The overall alignment is not too bad. PILL mismatch, really 12 degrees, positive sagittal alignment, but within normal, and then a mild dextroscoliosis between T11 and L4 of 10 degrees. Sagittal and axial MRI demonstrates reherniation of this L3-4 disc with caudal migration causing pretty significant central stenosis.
So 2 levels below that thoracolumbar fusion, he has blown out a disc. Below that, he has had laminectomies and a single level fusion. So Dr. Mundis, you're one of the world leaders of alignment, and you've substantially contributed to our knowledge of this literature. These alignment parameters are not perfect, but they're not terrible, I think, as Dr. Minisali said. Was this patient's future career in terms of spine degeneration of the lumbar spine preordained in that 97 car crash with a fusion despite having multiple levels below his L2 level intact? Or what happened here? Bad genes? Tell us a little bit about your insights in terms of this fulminant lumbar degeneration.
Yeah, it's probably the real question there. I would say the overall alignment, I would agree, it doesn't look horrible. I think you could probably nitpick that a little bit. Are you able to throw up those standing long films?
Mm-hmm.
One of the things I try to assess as it relates to the sagittal plane, coronal plane, I think is also indicative of him simply having some failure as it relates to his disc degeneration and overall degeneration. So when you start seeing these degenerative curves happen, those are typically, I think in this scenario, more related to just aging rather than anything else. The sagittal plane, though, there you go, thanks. Sagittal plane, I think, is probably a little bit different with a PI of 47 and a sacral slope of 22. It'd be great to know what this looked like 20 years ago. But I bet, just looking at his alignment here, he probably is more like an R1, a recently 1, maybe a 2. But if you can see that he has sort of a long sweeping kyphosis above, even has a little bit of upper thoracic kyphosis that's kind of leaving his head to go more forward. That seems to be a bigger driver than anything. And then I would take the next step and look at is what we call the lumbar pelvic angle, or the L1PA on him. And if I were to just eyeball that here, it should be about 3 degrees or so. And he looks like he may be a couple degrees off from that, so not terrible. So that tells me his sort of lumbar alignment is all right, or that regional section there is all right, but he may have an upper thoracic component that's maybe driving his sort of forward lean. If you look at what's called the C2 tilt, so a line from C2 into the femoral head and over to the middle of the sacrum, it's a bit positive. So that tells me he's starting to decompensate a little bit. So you add all that together and you're like, all right, there's definitely a mild deformity that's lurking there. And if I decide to reconstruct, it certainly could have an impact on what's happening down the road. I would say another interesting thing, if you look at, it'd be fun to see what an x-ray looked like prior to the spinal cord stimulator. It looks like he's starting to get a little kyphotic above where the anterior surgery was. Question is, does that stimulator sometimes lead to a bit more sagittal malalignment?
Are you a mind reader, Dr. Mundis? This is exactly one of my pet peeves. I have no statistics on this, but this is going to be my question to you. Do you think that these dorsal column stimulators actually lead to some form of Charcot arthropathy or structural decompensation through whatever, proprioceptive alterations, something like that?
Yeah, I 100% agree. Like, I think yes. And, pain is there for a reason, right? So if you have neurogenic pain that the stimulator is helping, that's one thing. But if it's affecting a nerve, right, a stimulator, then it's affecting a nerve. And so that means all aspects of that neurologic structure are likely to be affected. And so I do think that there is an element where patients maybe they don't perceive as much pain, but they're also not perceiving as much data from their legs back up to their brain, and vice versa from the brain back down to their legs. So I think it does interrupt that flow of signal. I mean, mind you, this patient only had the stimulator placed, not that long ago, earlier this year, I think is what you said. So probably not enough time to really cause a problem. But I think my curiosity lies in what happens to these patients in the long run with these stimulators and that have pre-existing deformities. I do think they escalate or they accelerate the degeneration.
Yeah, maybe we can put our heads together one of these days and try to make a scientific project out of that, because this has been my subjective observation for quite a while. And again, This is actually a harmless decompensation compared to what we frequently see. Now to the gist of the message. So this patient has battled with multiple surgeries. Efforts have been made to preserve the motion segments of what is now 3 segments, and one of them has become really a stenotic segment. Do we keep fighting the decompression fight, or do we say, hey, let's just stop this, let's give him a fusion, let's give him a structurally rigid spine that'll hopefully help his pain? Where does the fight end to preserve motion here?
Yeah, well, I mean, I think he's rapidly losing that battle. If you look at thanks for throwing the CT up there. Like, I mean, that just shows you, like, I mean, he's yeah, I don't think this is much of a salvage place anymore. You got to talk to the patient. He's 50. He's young. But I mean, it seems like the interval between surgeries is lessening, right? We're seeing that happen. It's like, yeah, I feel like a reconstruction probably is the best thing for him. His 4-to-1 looks a bit flat there as well on the CT scan. So, he's probably missing some lordosis at the bottom. He probably doesn't need much in his upper arc, but that lower arc needs to be fixed. And then he's got, looks like a wasteland of posterior tissue, right? Like doesn't look like there's any lamina left at all at 5, and 4 is like 80% gone.
A little better on the coronal here.
Yeah.
My pet peeve, full laminectomies in these kind of patients where maintaining a midline and facet joints would be so important. So T10 to pelvis and stimulator removal, talk to us about stimulator removal maybe, and anterior posterior, where there's been an anterior procedure done previously, far lateral surgery. So just pragmatic things in sequence, DCS stays or goes, and how high do we go and how do we reconstruct the anterior column?
So I think if there's a pre-existing, like true, like neuropathy, then that stimulator can have a benefit. So I think that's something I'm okay with keeping in the setting of a real neuropathy. If you feel like it's radiculopathy, it needs to go and get out of there and let the guy go live life. So in general, I don't believe that many patients have true polyneuropathies, especially not at this age would be a little bit odd, but he has had numerous spine surgeries. So it's a discussion with the patient. I'd probably be in favor of removing it. You can always put it back in. I would say, yeah, when they've had previous anterior surgery like that, I'd kind of go away from doing more anterior surgery. I think the risk is pretty high. I would rather, especially with all the degeneration, it's got a ton of inflammation in the front. Those vessels are going to get stuck down. I'd probably be more of a fan of either going lateral, I think would be very reasonable here, and then reconstructing him anteriorly that way. I think this is actually a pretty good MIS candidate. I don't do all that much MIS work anymore, but this is one of those where the deformity is mild. You can reconstruct the anterior column, and I would probably not go to T10 on him. I'd probably go to 12, or if you can sneak some screws into L1, maybe stop at L1, because you have this like natural built-in buffer as a transition to the rest of his spine. So I'd probably try to tie into his previous construct if I could sneak the screws past the anterior fixation. So that would be something I would be open to.
Yeah, all great points. Thank you. I think for us, we certainly like to employ the lateral approaches and MIS when we can. This gentleman had it back in the 90s with this, pretty large shark bite incision. I think that just steered us away from it a little bit, but I think still very reasonable. The spinal cord stimulator, we worked around and kept. And we did talk with the patient that it may not work, but we will do our best to preserve it. So in general, we proceeded with a robotic-assisted posterior fusion, T10 to pelvis, using S2AI screws. We did perform laminectomy and then intradiscal osteotomies posteriorly with interbody fusions at L3-4, L4-5, and then used the soft landing technique with Merceline tape at the UIV +2, so up to T8. And these are actually post-op day 1 standing films. Patient did pretty well. We don't have any further films further out yet, but overall, I think the SVA might be slightly worse, but again, post-op day 1 is a little bit tough to truly read that, I think. We got the PILL mismatch down to 3, and we also have this post-op CT that kind of shows that improved focal lumbar lordosis at 3 to 5 from which was 6.1 pre-op to 12.5 post-op. And these are kind of standard non-expandable E-lift cages for those two levels that we placed all the way anteriorly. And we didn't do too much compression posteriorly. Again, we knew that he didn't need all that much correction.
So Greg, any criticisms? I mean, this is an early follow-up case. We usually like to present more long-term follow-up, but we just collected some current cases here. Thoughts? And should the DCS, when do we remove the DCS? What do you think about this form of reconstruction?
Yeah, DCS, like I said, is plus my, you can take that thing out anytime. It's outpatient procedure, so I don't think it's an issue, you know. And if it helps his leg pain, great, you know. I think you can see his upper thoracic spine. That could be a bit of an issue for you guys. If you look at between T8 and T6, he's got a focal kyphosis there. And he kind of had that beforehand as well. That may end up, you know, biting him in the butt a little bit. I think his, you know, maybe if you want to be like critical of yourselves, which you'll see, I love being critical of myself. It's the only way to grow, but I'd probably say you're still flat from 4 to 1. And I, you know, ideally probably would have compressed a bit more back there to get the apex of this curve right at L4. But yeah, otherwise, hopefully his pain's probably a ton better now, I imagine, getting all that degeneration out of there. But maybe not at post-op day 1. I might take him a day or two, unless he's a tough German like you, Jens.
Surprisingly well.
Being ready.
No, this is not my case, so we can go after it.
Just very quickly, for anyone watching who hasn't seen it before, this is just a technique from the Neurospine Journal from 2021, but this is the technique we use for that Merceline tape at the UIV +1. Normally, we did up to +2. And so just for anyone who's watching, this is a nice reference.
Good. Thank you. So let's go for, you had the limited case? So, yeah, I know, calling this too. So Mark Kramer's going to come up next and show the other extreme, and I will take responsibility for that one. So have your wit extra sharp here, Greg. Mark Kramer is a neurosurgical colleague here with us from the University of Wisconsin, and great to have him here as well. And he was happy with the thrashing of the Seahawks by his favorite football team.
That's right.
The Packers football team. Glad to oblige your football fantasies.
Fortunately, I couldn't make it to the game myself. So thank you for the introduction. So this is the case I'll present. It's a 70-year-old gentleman who presented with back pain, leg pain, also some issues walking. Specifically, he said he couldn't walk more than 20 yards before he got numbness and weakness in his legs that prevented him from continuing further. He had a history of complete 2 to 5 laminectomies about 10 years prior. No issues with bowel bladder dysfunction. A couple pieces in the past medical history, nothing all that severe, fairly healthy guy otherwise. He's actually still a very active guy. He's still working and still enjoys playing golf despite his issues with walking. So here's his exam. You can see he's got some mild right-sided weakness, primarily down at the ankle. No other pathologic reflexes. He's a pretty big guy, 6'3", 100 kilograms. So I'll just scroll through his MRI here to start. And you can see it's a little difficult to tell based on the sagittal T2, but because he's obviously developed a bit of a coronal deformity. But it's, I'll just kind of describe what we're seeing. So 2 to 5 full laminectomy, spinous process and everything is gone at all those levels. He does have some pretty severe stenosis. You can see here at L1-2, just above where those lamies were done. And if you scroll through the axials, you can see that he's got pretty severe facet hypertrophy and arthropathy. And if we look at his standing flexion and extension films here, you can see that he's developed this coronal deformity bending off the left side there. And on flexion extension, no abnormal motion anywhere. but preserved motion still at 5.1, just below where all these laminectomies were done. So here's the scoliosis films. He's got a positive SVA of almost 11 centimeters. His PI is measured at almost 50 degrees, and his lumbar lordosis is almost nil. So he's got a huge mismatch. And we ended up getting a myelogram as well to kind of put everything together here. And you can see based on this, again, pretty severe stenosis at L1-2. He's got this arthropathy, as I already previously mentioned. And then if you look at this coronal, you can see he's got some listhesis laterally, multiple levels, L2-3, L3-4. And if you look at his thoracic spine, no significant stenosis above, but there is some loss of the normal thoracic kyphosis. So in summary, 70-year-old gentleman, still very active, enjoys playing golf. He's got previous laminectomies 2 to 5. He's got symptoms of neurogenic claudication, and he's got a pretty severe sagittal imbalance, almost 50 degrees. He's got this dextroscoliosis, question mark iatrogenic after his laminectomies.
So this is we should add to that. Thank you, Mark. That was an excellent presentation. Very active man. He plays golf. He's had both hips replaced, as you can see. He has no other arthropathy, diathesis, or inflammatory disease encumbrance, but he really suffers from this. He can't walk anymore. The radical laminectomy was done against one of my least favorite surgeries. Has things, and he's structurally decompensated. He has a neurologic problem, but he would very much like to play golf still. He has a distributorship. He's a hands-on kind of a boss guy, just a super guy. The laminectomy, as you can see, was taken up to and inclusive of the L2 vertebra. Again, a very radical kind of a surgery. And here we are, end-stage structural disease, L2 through 5. Surgery, I think, is inevitable because he has severe stenosis, but there's a structural component. Where to go, Greg?
Yeah, so Mark, pull up those x-rays again. And just to make a side point here, you want to critique his hips?
He's a neurosurgical colleague.
I know. That's why I wanted to. I think it's important.
First tips. And Dr. Hogg said
you could phone a friend.
I'll phone a friend immediately.
Yeah, it looks like on his left hip, he probably has some eccentric wear. The femoral head is riding high there. So that's something I'd want to ask him about. And he's also pretty anteverted. You can see the clock is facing us, and it's also very vertical. Both of them are pretty vertical. And then, yeah, the right one version looks okay, but be concerned about that left hip. And
yeah,
I don't see any osteolysis or anything like that.
Not yet. Yeah, until that head sits almost. Mark, do you see that? Yes. The center of that femoral component should sit in the middle of that acetabulum. You can see it's how it's riding high, right? That just means that he's been wearing the stink out of it. But the other thing, if you look how lateralized those acetabular components are, right? They should be medialized more. So it looks like whoever drilled that acetabular component didn't put it in. And if you look at the kind of stem they used, it would concern me. Just FYI. And then I agree, they're anteverted relative to what he's doing. The other thing that's interesting on him is if you look at his pelvic tilt, it's elevated, but it's not 30. It's like probably 20, 25, something like that. And for your pelvic tilt being your primary mechanism for compensation, one of the reasons when he's decompensating is probably because he's got so much stenosis, right? So he's probably having to keep his back in some flexion just to try to get some relief from his stenosis. So he's probably not even retroverting as much as you would typically. Do you guys use the bowel classification at all for coronal deformities?
I typically don't.
Yeah,
but
cool. So I'll show it to you in my talk. But if you look at him, he's deviated off to the left here, right? And so if you think about, if you were to fix, so which curve is stiffer? The bottom one, like the fractional curve from L4 to S1, or the one above that, that's say on this guy's from like T12 to L4? Which curve is the stiffer curve?
I'm going to guess it's actually the higher curve, but I don't have
Typically the lower. So the fractional curve is like harder. The bottom one is usually harder to fix. And it's because it's kind of locked deeper into the pelvis. The lumbar curve, oftentimes, because it doesn't have any ribs around it, it doesn't have the pelvis constraints of it, it's actually a little bit more flexible. And so if you think about what happens in this patient, if you fix L4-5, but then you really fix the other part of it, and it's going to fix pretty easy because he's had the laminectomies there. And once you release the facets, he'll probably fix pretty good. You're actually in danger of knocking him even further to the left. Right. So this is a bow, we call bow C. I would say is in danger of malalignment post-operatively because of that. So you have to pick your levels and you have to really, really fix the fractional curve. So the L4-5 tilt that you see there, 5 on S1 looks pretty level, but L4 looks really tilted relative to L5. And you got to get that thing spot on before you even consider correcting the scoliosis above it. So really critical point on that. Sometimes you can't do that with just a one level surgery at L4-5. You may have to go down to S1 with the pelvis to be able to manipulate that. His sagittal plane is a bother. He's a PI of 50, which puts him in a probably the way his spine looks, I'd probably call him an R2, Russelli type 2. So he needs a sharper curve at the bottom from L4 to S1. The inflection point is typically around that area for the bottom, the lower and upper arc. And then he needs a relatively straight spine above that. He's got thoracolumbar kyphosis, or I should say upper lumbar kyphosis, from his surgeries. So this in my hands, even in an active guy, I would probably do a lower thoracic to pelvis type surgery.
All right, in the interest of time, let's move forward, Mark. So this is what we did not do, but we had.
And Jens, tell me to shut up if I'm talking too much. Like
You are awesome. This is a treasure trove, and our audience around the world appreciates this very much. So I had, I must say, extensive discussions with this man. It's a very intelligent man. And I told him the gold standard would probably be a T10 to pelvis fusion, but he's done his own reading, and we did this. So,
Exactly.
Mark.
So we did a midline sparing laminectomy at 1-2. And then what we did.
Laminotomies.
That's right. And left obviously all the interspinous ligaments intact. And then we worked our way down through all the scar, the previous laminectomies, and performed interbodies with intradiscal osteotomies at 2, 3, 3, 4, and 4, 5. And it's not well shown on these x-rays. It's maybe a little better shown on the CT, actually. You can see that we kind of asymmetrically placed those cages. So just one cage level.
That's great.
We were able to pop open that side at 4-5 on the left, you can see, and also at 3-4, and then place one on the right at 2-3. And then we're able to kind of compress across that side to kind of realign things. And that's just a floor shot from the OR showing us putting those in. I think overall he did well after the procedure. He had a bit of a long, prolonged hospitalization, and he did end up developing a bit of a traction injury, we think, because his left leg, unfortunately, developed some new left leg weakness post-operatively. Discharged to rehab, and he's actually getting some of this function back already, but that's
interesting, huh? Like it's the whole plexus.
Yeah, that's on the left side. It was there were no significant neurologic injuries. The revision dissection was painful, but very doable and out DRGs. I don't think there was any dural tear, anything, no neuromonitoring issues. Again, we did 3-level IDOs, and we're very pleased with how the surgery progressed, but he clearly had, the main functional limitation actually for him was his hip flexion weakness on the left side. And again, there was no neural element entrapment, so that was the downside of it. Pain-wise, he's very happy, and he's actually relatively optimistic. He does not have a brace on his left side. I think he uses high-top shoes, but he needs ambulatory assist devices with forearm crutches now for his hip flexion on the left.
Okay. Interesting. Yeah.
So he's just he's I think 6 weeks or so out.
What's your protocol on doing like post-op EMGs? Do you guys ever get those, and do you think they're valuable?
The 3-week mark, but he's above L3, and again, I have a low threshold towards doing that, but right now there's no therapeutic consequence. We've imaged him pretty aggressively, and again, he is actively engaged in a daily home exercise program with my favorite tool, the recumbent stationary bike, and he's doing that very diligently. So I'm actually quite hopeful. He has no nerve pain, but he has weakness. If you go back to the post-op images, so the neurology had me concerned, and again, this is the humbling thing about our job, because we can do everything as well as we can. Do you think that this is totally insane on my part to just do a very limited fusion with a decompression above this fusion, trying to do midline sparing surgery? Is this bound to fail? Do we have to go to the pelvis if you look at that L5S1 junction?
No, I'm actually pretty darn impressed, like how it flattened out like that. I think it's great. I mean, the guy's 50 years old, so this is not his last procedure, you know. Unfortunately, it is what it is, you know, but he probably understands that, and I think as long as he does, I think this is, you know, a very acceptable alternative. You know, you left 5-1 alone, give it some life and see how long it lasts, you know, and then you put the pressure off the nerves above. It looks really nice. Yeah.
So far, so good. Yeah, we'll hopefully not have to revisit this too soon, but obviously I was...
A lot more longevity than what he had, that's for sure.
Yeah, no. All right, let's go for a more extensive thank you, Mark. That was nice. We'll go to Dallas, Texas, to a less confident-looking fellow because of the Cowboys. Our Cowboys fan, Cameron Hogshead.
I'm used to it by now.
He's used to it by now, yeah. We commiserate on Monday morning.
Every year there's so much hope, though.
Every year is a new year. That's what we say.
Yes, it is.
So this is a 59-year-old male. He's worsening back pain and left greater than right radicular pain. You can see his standing films in clinic on the right there. It says back pain is often more bothersome than his leg symptoms. He's no longer able to stand upright. He's been hunched over for the last 2-3 years, not able to stand upright. He's unable to walk longer than 30 feet. And now uses a cane for assistance, previously independent ambulator. Worked as a program manager for a nonprofit organization, not giving too much information away, but he's now on a disability due to debilitating back pain. He's tried physical therapy, all the epidural steroid injections, pain management meds, Suboxone, activity modifications up to this point. He does have a past surgical history of 5 lumbar decompressions about over 20 years ago, multiple microdiscectomies and laminectomies, and then past medical history of rheumatoid arthritis and high blood pressure. He takes an oral monoclonal antibody for the RA daily, and then non-relevant social history. Does have some left leg numbness, no real weakness on his exam. He initially presented, he had a BMI of 33 and a ODI of 66, a crippled per workman's comp eval. Those are just some relevant labs that he had. Was osteopenic, was started on bone health management medication with vitamin D and calcium, and then also given strong advice for protein intake, calories to bump his albumin up a little bit. So going back to his measurements here, he does have kind of a high, towards the higher end of pelvic incidence of 55, and then you can see he's decompensated, kyphosis and tipping over an actual loss of lumbar lordosis at that particular L4-5 segment with degenerative collapse. And then a huge PI-LL mismatch. And then you can see his pelvic tilt is much more than your usual 0 to 20. It's just kind of retroverting a lot to try and keep himself back. And then he's also hyperlordorsing through his cervical spine, also try and bring him back from tipping forward. I believe his SVA was about 11, and then his CVA, he does have a little bit of a coronal malalignment there of like 2.7 centimeters. So there on his standing films, you can actually see a little bit of a truncal shift too, and some very subtle pelvic obliquity. And then you can also look at your CT scouts and just see the dynamic changes in imaging when the patient is laying down. So it's always helpful information to gather, and you can see his truncal shift actually corrects a little bit, and he flattens out a little bit, that upper lumbar thoracic spine like you're mentioning. This is his MRI, and you can just see here, it's a pretty much a boneyard back there. A lot of junk, a lot of degenerative collapse, disc herniations, moderate to severe stenosis at those L3, L4 levels with pretty severe foraminal stenosis as well.
So with the limited information that you have, and this is a nice synopsis, appreciate that, Cameron. I always get asked by patients, what happened here? Is this a scoliosis? Was the previous surgery not done well? Is this just degeneration? Especially these lateral aestheses here, like what we see very impressively at L3, 4. What happened to this man? What caused this?
What do you think? Not Jens, but remind me your name again. I'm sorry. It's Cameron? Cameron. Yeah. What do you think, Cameron?
Yeah, obviously multifactorial. He's got a history of back issues in his family. I don't know if there's maybe a subtle genetic component, but he's had previous multiple back surgeries. He was on the obese side. You look at his MRI, he doesn't have the best muscle tone back there, so it's decompensated a little bit, and then he's had those previous decompressive surgeries. Might have been a kind of multifactorial play there and how he's decompensated.
The easy answer. And then he has this inflammatory disease history.
Rheumatoid as well.
There you go. Yeah, huge, right? So unlike your last guy that's, at the age of 50 has a terrible looking spine, is out golfing and doing that kind of stuff. That guy is like, if you look at his muscle mass, is very different. If you look at this guy's psoas, he has fatty infiltration in his psoas, right? Like this guy's very deconditioned. And you can tell that from his spine as well. So 100% agree with the multifactorial nature of it, but I think the combination of inflammatory arthritis, obesity, maybe some bone density issues, and then along with Jens's favorite surgery from 20 years ago, this was a bit of a disaster in the making, with all of that.
So one more side question before we go into the surgical question. Next to dorsal column stimulators, one of my other favorite pain management strategy is opiate ligand medications, buprenorphine specifically. It's widespread here. Right next to ketamine, in ketamine clinics, we have buprenorphine given out like sand here. This is like amazing. What do you do when we talk about major surgeries in patients who are on buprenorphine? Do you try to get that reduced? Do you try to just live through it and overdose the patients to try to get some modicum of pain relief? How do you handle this as a spine surgeon who I'm sure in fellow West Coast territory has that same problem of buprenorphine being given out as the new mantra for pain management?
Yeah, we 100% get them reduced. As a matter of fact, I feel like the resilience of surgery is very much predictable by a patient's ability to control their pain management. So in this patient, if they're on high dose of buprenorphine, I'm like, listen, you got to get down. We have morphine equivalent levels that we get patients to before surgery. We won't even operate on you unless you have like cauda or something like that. So elective spine surgery does not happen unless you're at 30 or under. So you're gonna hurt for a while, but it's gonna show me whether or not you're actually able to do it. Because if you can do it, that tells me you're also gonna be able to do your rehab. You're gonna be able to engage in your post-operative course. So we're pretty aggressive about getting patients off the drug ahead of time.
Yeah, same here. So now to the surgical question, and these are no fun conversations. I was impressed with this patient, I have to say. He was very receptive to the multidimensional prehab measures. I usually get into endless debates with patients and try not to be too Germanically dictatorial, but it's a challenge. So this patient has a couple of weird things. So he has this lumbosacral transition anatomy. If you can go through that, this is really nicely done, Cameron, the coronal. So he has this kind of a semi-assimilated 5-1 vertebra, semi-sacralized. And then he has this pretty brutal 3-4, 4-5 disease. 2-3 looks almost ankylosed again. So what do we do and how far do we take this?
So, yeah, great for pointing out the lumbosacral anatomy. I was about to ask Cameron about that. There's the Castelvi classification, which really nicely describes all that. This is a unilateral, which, you know, theoretically, if you needed to get an interbody there, or you needed to do correction at 5-1, this one would be pretty simple to get through because you have basically just unilateral, relatively posterior base connection between the transverse process and the sacrum. If you go back to his plain films, there's a couple things that bother me on him. He's unlike the last guy. This one is decompensated, right? So he has a retroverted pelvis, but then is also decompensated. So if you look here, he's trying to everything he can. So he's maximized his ability for pelvic retroversion, and then he's still failing on top of that. If you look at there's an angle that you can draw between C2 to the pelvis and then up to T9. And the larger that angle is, the higher the failure rate is with the lower thoracic endpoint. He's at risk of that. He's also got this inflammatory arthritis, which we have to take into play. And then we also have to think about bone quality. So this is a patient where we would probably pretty meticulously look at the Hounsfield units, even though the data suggesting whether or not that's helpful or not is still out there, but I do think it's at least a surrogate that we can measure. But I would probably look at the House units at the lower thoracic versus the upper thoracic. I think he needs a relatively significant realignment procedure. And I bet if I'm looking at this right, he's probably going to end up being an upper thoracic case for me. I don't trust this guy's muscle tension. I don't trust his arthritis. I don't trust his bone quality. But I would certainly be prepared to go high on him. I don't think he needs a PSO or anything like that. He's got a lot of disc spaces that are open. 5-1 has a decent amount of lordosis in it. His 4-1 is short, but his main focal problem is at L3-4. So the other thing you could consider is doing something short. So instead of going really long is, hey, can we stop this before you even get to the upper thoracic spine? And that would be a bit controversial, but I think would be a reasonable consideration as well to try to spare him all the entire top part. But that means you're stopping at around L1 before you're getting up to the upper part. And I just don't know if a guy like this sounds like he might fail that pretty rapidly. So
Great points. Cameron, take us forward so that we can get to Dr. Gold.
So summary there, like Dr. Chem was saying, he has been pretty diligent with his bone health supplementation and has lost weight. He made it down about 4 points down to BMI 30. So these are some intra-op photos that we have. It's a T9 to pelvis with a quad rod construct and multi-level eccentric intradiscal osteotomies, 2-3, 3-4, and 4-5 that you can see there on the right with medial iliac bolts and connector working across and to the working rods there. This is a CT scan here. And so as discussed with the transitional anatomy there, the lumbosacral, we opted against a interbody fusion. And so a pretty good result coronally with good correction, and then achieving pretty good lumbar lordosis there from the L4 to S1 with the releases of those collapse segments.
Do we have any plain films on him?
We do. I wasn't able to upload them over. He has clinic. He followed up in clinic with plain films that have maintained alignment, but I wasn't able to upload those to the system. And so these are kind of the befores and afters, and then you can see some of his realignment parameters. And so obviously off immensely previously. And then here you can see PILL within more than reason, and then good coronal correction.
So to a flaw, I accepted the L5 as one junction. I felt that we could get enough lordosis through the 3-level IDOs above that. And one of the hardest reduction maneuvers, maybe you can share some tips and tricks from your end, is these lateral ascesis, these rotatory subluxations, which we see manifest here at 3-4. Any thoughts on how to reduce those or realign those?
Yeah, I mean, I would say if you're doing it all posterior, you just have to do pretty aggressive releases as you've done. You know, they're always tricky. In general, I kind of think of it a little bit more, if it's regarding the coronal plane, I think of it a little bit more as head over pelvis. So I just want the spine released enough so that I can push the spine back to where I want it. And sometimes that requires more segmental work, but in general, it's more the whole region of the spine. So you can use things like kickstands to knock that over a little bit more. That would be an option if you're still dissatisfied with your coronal alignment, which you can do once you have one rod in for sure, and just distract off the pelvis relative to the side. So in this case, we've done on the right side. And then sagittally, it's just a matter of making sure you get enough disc height anteriorly and you're able to compress in the back. But it looks like you got plenty of disc height there at 3-4 to be able to do some of that work, and clearly able to realign that segment a lot better. It was really kyphotic beforehand. I think, lateral would have been another good option there too. I think just the big open disc space like that, a lot of air in that disc. Probably could have done a lateral there as well. So I think that's, is always a reasonable option if you're into the 2-stage procedure.
Yeah, no, it's fair points. He actually did very well, right? I mean, he had no problems. I was actually very pleased with him because these patients who are on Suboxone type medications are a
good to handle.
This was a dream patient, I have to say. He was amazingly compliant preoperatively. He has a very strongly determined wife, which was helpful here because she clearly took control of matters and very pragmatic and supportive. So, but he did very well so far. Again, we don't have long-term follow-up. I think he's within a 3-month window still. But
left post-op day 3 or 4 or something like that.
Yeah, post-op day 3 or 4 with this magnum surgery. We did not go to the upper thoracic spine. We have a paper, and that reminds me, I have to ask that fellow to give me the manuscript revision. We actually do have a sarcopenia paper that does show that sarcopenia is one of the leading problems in our hands, at least, for adjacent segment degeneration and long fusions. So your point is absolutely well taken. And in our structural assessment, not well enough appreciated, I think. So thank you on that one. And let's finish with Dr. Colin Gold, who has no conflicts of interest regarding football teams to declare. He's a neurosurgical colleague from Iowa. And
he is from New Jersey, so maybe Giants.
No, he has no football proclivities. Drones and rock climbing.
All right. So the first case is 80-ish-year-old woman who presented to clinic for the most recent event after a 3 months follow-up for a T10 to pelvis posterior spinal fusion, spinal cord stimulator, which was placed about a year and a half prior to this index surgery. And she presents with mid-back pain. Pain wraps around the lower ribs on the right side, is worse with activity, slightly better with rest, but never really goes away. She did have lower extremity pain prior to the index surgery that has completely resolved, complex past medical history of lupus, chronic steroid use, chronic kidney disease, osteoporosis, and an episode of pneumonia after the index surgery. She had a DEXA prior to this index surgery about a year or so before. T-score was negative 1.4 at the left femoral neck, and she had previously been on alendronate and reclassed years before that. Here's her neurologic exam, essentially neurologically intact with some slight hip flexor weakness, possibly pain limited, and absent patellar reflexes. Oh, and patient is ambulatory with a cane or a walker normally, but is able to live with modest assistance at best. Here's some x-rays on the left side are before the index surgery, and then on the right side are the after the index surgery. As you can see, your initial Cobb angle, mostly centered in the lumbar spine, was 28 degrees, lordosis of 33 degrees, PI estimated, because you can't see the femoral heads, of 56, and pelvic tilt 35. And then on the post-op x-rays, you can see improvement of both the sagittal and coronal parameters, but there's a new PJK with a fracture of the T10 level, I believe, and displacement of that screw. And here's a CT demonstrating this. Her Hounsfield units at L1 prior to the T10 to pelvis surgery were 106.
What's that tell you, Colin?
Sorry, go
Yes.
ahead. Go ahead, Greg.
I was saying, what's that tell you, Colin, if they're 106?
That would put her in, I don't know if you can designate it as osteoporosis, but I believe less than 110 is in the warning zone.
Yeah, you're right. You can't diagnose them off of Hounslow units, but you know the warning signal should be going off, right? Yeah.
So I'm not familiar with this patient. So these discordances or discrepancies between DEXA scans, again, this was a femoral head measurement that I heard here. I'm not familiar with this patient, I must say. So this is discovery for me also. And Hounsfield units are not uncommon. And the regionality of bone density differences in the spine is pretty profound. So what do you make of that if in doubt? And what was done wrong here? Should this patient have been banded more, or a priori, given her age group, taking higher? Where do we put the bone density information into practical applications?
Yeah, I think it's an important consideration. I think if her DEXA was minus 1.4, that's kind of the best data we have. So I don't think I would fault the bone quality. The Hounsfield units would make me a bit concerned about stopping points as far as UID, et cetera. I think when we look at this, probably what I would say is that if you look at spine shape, if you look at the lower arc versus the upper arc of lordosis, this looks like the shape is a bit more like an Arusali 4 when she's probably more of a Arusali 3. She has some thoracolumbar kyphosis, which she probably needed to keep. She's flat in her lumbar spine. So I probably think she needed a bit more lordosis from 4 to 1. I think she needed to have her kyphosis start a little bit earlier. If you look at that rod, the way it's bent, it's all the way straight to the very end of the construct. So it doesn't leave any room for her to go into kyphosis. So for her, I think this is a natural progression of alignment more than anything else. So I think it's probably just a shape issue on her. The shape's wrong.
And what do you think about bracing in patients post-op? And again, the rostral contouring of rods, was this too aggressively lordosed, that working rod? What's your protocol there? Do you have a bracing prescription for these older patients to kind of just tell them to stay straight? And do you bend the rods forwards a little bit more, since you talked about shape?
Yeah, so for me, I would have put more lordosis in at the bottom, and then I would have gone to T4 probably, or T3, and I would have reshaped her thoracic spine, because I think it's part of her disease state. So in these patients, I either try to stop short, like at L2, or I try to go high, like to T4, T3. I think with her Hounsfield units, age, I think she was at high risk for this even ahead of time. And I probably would have been in favor of going higher up on this patient, which is a bit more aggressive than I think I would have done surgery 5 years ago. But at least where my brain is now, I don't think there's much role for bracing. Doesn't make much sense to me. I think if you've put the spine into a neutral alignment and you make them stand without effort, then a brace is unnecessary. So I haven't used a brace in probably 8 years.
So how do we solve this problem now? Do we have to do a corpectomy, and do we go to T4 or T3? Do we do?
How far out is it?
Just 3 months, right? Did I hear that right?
Yeah, about.
So it's an early failure.
Perfect. Because then you can go back in, pop those rods out, extend her to T4, and just shape the spine how you want it. That's probably what I would have done. I wouldn't worry about the corpectomy and stuff like that unless you have imaging that shows that you have some, horrible herniation there with spinal cord, injury that's impending, which I just do a Lamy there probably. But you don't want to overcorrect that thoracolumbar spine now, right? Like it needs that kyphosis. So it just needs a bit more lordosis lower down with an apex probably of L3. Looks like to me like the apex is a bit high here. It's probably more like at L2 or L2 or higher. So you want to drop the apex a little bit lower with a sharper lordosis at the bottom, and then reshape it higher up with more kyphosis.
All right, take us forward.
All right, so we did posterior T4 to L2, arthrodesis T4 to L2, segmental fusion, and then we reduced the fracture at T9, T10, T9, T10 interbody, and then 3-column osteotomy at T9 and T10, partial corpectomy via costal transversectomy, and then laminectomies from T8 to T11. And this is the postoperative course. The patient did very well, actually, in the hospital, discharged to a SNF in post-op day 4. No events during the hospital stay. Initially went to SNF, but was able to return home and return to her previous level of function of ambulatory with a cane or walker. And here's her post-op x-rays 2 years after this surgery.
So what's going on the rostral level? Is there a beginning subluxation at that T3-4 level? And to Dr. Mundis, should we use hooks, cables, rostrally to kind of prevent this vulture neck, this forward tilting of the cervical-thoracic junction from happening?
Yeah, I think it's sorry to belabor the shape thing, but the shape is still wrong. So I think it's still a shape problem. And now, interestingly enough, look at her pelvic tilt. It's like it's going to 0. So is she wonder if she's like leaning on something there, or if she's like got her walker.
It looks like her arms are not forward in this.
Yeah.
Sure.
I think hooks and those kind of strategies, Jens, I think are good. If you look at data, it is supported, to do things like hooks or bands and things like that. I think the best support though for prevention of PJK is shaping the spine well, and getting it back to where that patient's neutral line needs to be. You can see here, like you're really flattened out the thoracolumbar spine, right? So it's really straight there. So it has to go, the kyphosis has to go somewhere. So you just shot it north. So now she's kyphotic high instead of being kyphotic low.
So she might not be done, but clinically she's doing well for now, from what I gather.
Yeah, this patient's now in her mid-80s and has mid-back pain.
Enjoy the mid-back pain. Exactly. Yeah. So hopefully she's done, right? Hopefully she's done. And by the way, we get to be critical. We all have patients where,
Greg, the reason I showed this, I think all the points you made are excellent. And I mean, once you do these surgeries on these patients, whether you go small or big, you kind of own them. And then fortunately, I think she's starting to develop some, distal proximal junction issues. So.
Yeah, no, this is a lifelong avocation, and again, trying to re-educate those patients and repolarize them and work on straight posture, aside from all the very valuable points you made, is just critical. And it's a difficult battle because as we age, most of us want to tilt forwards, and a lot of people just lose muscle tone. So,
And there was another case, I don't know if we have time.
That's fine.
Okay.
Dr. Barnea said, you need 100 deformity patients in your practice and you're set for life.
Yeah.
yeah. So Dr. Gold, thank you, and to our fellows. Dr. Gold had another case, but we ran out of time, and you had so many good points to make. Ben, can we just, before I introduce Dr. Mundis, flash in a self-advertisement for tonight? We have a very unique program. We have our quarterly an evening with a spine surgeon at 5:15 Pacific time. And this is not a spine surgeon this time. These are the Viscogliosi brothers. All three are going to be together, interviewed with our TBI colleagues. They made history. This is a venture capital fund that basically invests in medical technologies. And they are the ones who brought disc arthroplasty to our shores and supported it with research in an unprecedented depth and duration. And we want to just have an informal chat. It's been a very popular program with these three brothers as to how they saw their role in terms of forwarding medical technologies, in this case in spine surgery, and changing our options for treatment, so avoiding fusions and disc arthroplasties and other motion-preserving technologies. And we thought they're very engaging people, and again, they affect our lives as practitioners substantially. So please dial in at 5:15 for what should be an entertaining and insightful evening. There's no product advertisements or anything like that. It's simply how do we fund medical research related to devices in conjunction with money. So dial in tonight. But to the present date, it's a super honor to have Dr. Greg Mundis, Jr. here from San Diego, from the Scripps Clinic. He has a unique background. He did his medical school in Missouri. He did his residency in Oklahoma, and he did a fellowship in the world-famous San Diego Spine Fellowship Program, and then joined the practice there based on his tremendous performance in 2009. He's a unique colleague in that he's also been the CEO of Global Spine Outreach. He's a member of ISSG and published in the multiple hundreds, and many of those publications he referenced, but out of modesty, he didn't reference himself there. So the understanding, the advancement of the understanding, quantification of spinal deformities has been largely influenced with him and his colleagues. He's a renowned deformity surgeon, both for pediatric and adult patients, and is a known resource in San Diego. And it's a real treat to have him here today. Und spricht Deutsch auch. Servus und guten Morgen. Thanks for being here and sharing your insights in spinal deformity surgery beyond the commentaries which you gave already. So thanks for being here, Greg.
Yeah, thank you so much for having me. And absolute honor to be here with you guys today. So super excited to share some kind of the latest and greatest of what I think is where we currently are at with spinal deformity. You guys see my screen okay?
Yes, nice and clean.
So we're just gonna pound through this. I got a lot of content, and then we'll probably have to stop a little bit earlier. I may swing around in this talk a little bit, skipping some slides to try to get to some of the meat and potatoes that I really would like for you guys to learn. But here are my disclosures. Not really relevant to today. We're not really going to talk about product. So my goal for you guys really is to learn some of the fundamentals of radiographic analysis, and then be able to describe some new parameters that I think are really important: the lumbar 1 pelvic angle, the T4 pelvic angle, the C2 pelvic angle, and the C2 tilt. So like having an understanding of those will help you with understanding your segmental, regional, and global alignment. And then I want you to hopefully take you on a journey of how to be methodical in planning and then hopefully executing the surgeries. I'd be remiss to say that these are probably the strongest influencers on my life right now. Dr. Lelek and Dr. Rousseli in France, and then Jeff Hills out of San Antonio, Mike Kelly here in town, and Camila Molina. All of them have contributed to this talk, so this talk is not all crafted by myself. I'm using slides that they made and that we worked on together, but just want to make sure that credit is given to where it's due. So one of the things I like to say is, like, why am I on this journey of understanding deformity better? Well, I used to say I'm always striving for perfection, but then I found myself failing all the time. So I recently heard the wonderful line, which is, it's not so much about trying to achieve perfection, but rather pursuing mastery. And that's really what this journey really recognizes. So like for those of you that are, on this journey, especially the trainees, like, how do I help you guys leapfrog your peers? And by that, I mean myself, so that you don't go on a 10 to 15 year journey to get to where maybe I am at now, or where Dr. Chapman is, et cetera, is so that we want to be able to get you guys caught up to speed faster. And so I think chasing mastery is one of those ways to do it. What are we trying to avoid? Well, I think we're trying to avoid this scenario where we do a lot of surgeries on patients that ends up with a spine that looks like this, that ends up requiring a pretty nasty reconstruction. Here she is just standing. Here she is walking, and these are just like really debilitating deformities for patients. And I think a lot of it stems from our, lack of understanding on what's required. So then they need these big operations to get realigned. And while they're cool surgeries and you can help patients out a bunch, it's still like, it'd be really nice to not have to do this to someone. So the demands are huge on our society and everything's expensive. So when I think about this, when I think about these surgeries and these deformities, it is a complex problem. It's like, how do I get this tractor up into this truck? And I think if you think about things logically, you plan them well, then you can actually come up with a plan that you can execute. And then, things that may have been impossible or seem impossible, especially when you're in training, you eventually kind of work things out and things are able to get accomplished that you didn't think to be able to accomplish. So that's kind of a little bit of deformities. I used to say it's simple. It's actually, I don't think is that simple. But I think time, energy, and effort will get you there. So here's the take-home message. Be methodical in how you evaluate adult deformity. In the coronal plane, we want to put the head over the pelvis. And in the sagittal plane, the shape really does matter. And we want to work from the segmental alignment all the way to regional and then ultimately to global alignment. So when I say be methodical, it's mainly being organized. And when you approach adult deformity, there's a way to do this. The good news is it's a learned skill. So this is something that no matter what age or station you are in your career, it always can be learned. So that requires you to understand the deformity down to its elements. And then you're basically deconstructing to reconstruct, and having a sense of that is really important. Again, coronally, it's pretty easy. Like at the end of the day, patients don't care as long as their head is over their pelvis. Even if their spine is curved in the middle of it, if they're standing upright and balanced, they're pretty darn happy. The sagittal plane gets more complex because there is the tolerance for failure is lower. And so we have to be a lot more spot on in the sagittal plane than we do in the other planes. And the consequences are potentially devastating. So when it comes to the coronal plane, there's not much role for the segmental realignment. When in deformity surgery, I think there's a huge role for it when you're treating an individual segment. So if you're just doing an L3-4, I think how you align that matters. But if you're doing it in the context of deformity surgery, it doesn't matter that much because you just want to put the head over the pelvis. The regional curves do matter. So, and this is where we'll help you, help understand the fractional curve, the main cob, and then the reciprocal cob. Global alignment really is the C2 over the sacrum. And then there's other things that come into play, and we'll touch on those as well. The sagittal plane, the shape really matters. And so the segmental alignment actually matters a lot as well. So it's really important to realize that what you do at one segment affects all the other segments in a very reciprocal manner. And then when we think about the regional, we're going to think about the lower arc of lordosis, the upper arc of lordosis, and then the entire thoracolumbar spine. And then the global alignment really has to do with the relationship between T4 and L1, as well as the C2 PA and the C2 tilt, and we'll get into those parameters at the second half of this talk. So when we talk about the coronal plane, a couple things we want to define. One's that fractional curve. So it's the curve that happens right off of the sacrum. This usually typically ends somewhere around L4, and you can measure it pretty simply just by putting a cob measurement down there. It can be higher, but typically it's L4 to S1. This is that classification I was talking to you guys about, the bowel classification. I think it's super helpful because it lets you kind of think through this problem in a little bit more of an organized manner. So the bow A's, which are on the left, have a spine that is neutral. So the head is sitting between the pedicles of S1. So they're basically standing upright, and that's our main goal. Our main goal there. When you fix the fractional curve in these patients, it goes off to the left. When you fix the lumbar curve, it goes off to the right. So in these guys, you just have to be, the only thing you have to be worried about is getting a balanced correction. If you get a balanced correction, they'll still end up with their head over their pelvis. The bow B's, the B's are leaning towards the concave side. These are awesome for MIS surgery because the fractional curve takes you towards midline, as does the main lumbar curve. And so these are ones that are much more amenable to doing like minimally invasive reconstructions because you don't have to manipulate the coronal plane as much. So the type C's, these are the ones that we showed, I think you guys showed 2 of these cases today, where the patient is coronally offset towards the convexity of the main curve, right? And that's the main curve being all the way over here. And so when they're towards that, the issue is you have to fix the fractional curve. But because of its offset, a lot of times you don't fix it as well as you would like, but you're able to fix the flexible lumbar curve a lot more. And so a lot of times you're flexing the main curve more than you're fixing the fractional curve. And on these guys, you've got to be really aware because it's pretty common that you're actually able to send the patient further off in the coronal plane, so their coronal offset gets worse. A couple other things to note on the coronal plane is the leg lengths. I do think it matters a lot in this group. So, if you're interested, get your scanograms or get your leg length films or your EOS film, measure the tibias, measure the femurs, understand what's happening in the hips, and then you'll be able to identify where the problem is. So on this patient, she basically has a leg length inequality, mainly because her femoral necks of her hip reconstruction are different. So one leg is longer than the other. So you also want to understand the causes of your fractional curve. There are different reasons why they have the fractional curves they have. We saw some you see a sacral dysmorphology where the sacrum itself is actually misshapen. Like we saw today, you can have transitional anatomy. That's another one where you just are able to see that a lot better with the CT scan. Again, leg length inequality would be the other one. CTs are super helpful when evaluating this coronal plane. So just make sure you're looking at them, especially that lumbosacral anatomy. It'll teach you a ton about what's happening at the bottom. Curve flexibility is really important in both the coronal and sagittal planes. So always do evaluate that. You can use your scout films from your CT or MRI. We actually do supine films as well. But I do think it's really helpful to help you understand, how hard the day is going to be in the operating room. So here you can see where the patient's fractional and main lumbar curve actually were basically unaffected by positioning. And again, use the modalities that you have to understand it. So when we plan, you want to classify it by bow, and then you want to understand what you need to do to the fractional curve. Do you need to fix it at all? And if you do, how do you want to fix it? Do you do asymmetric TLIFs like we saw a bunch today? Those are a very powerful way of correcting the coronal plane. Do you do things like an anterior release with an A-lift and posterior release? Do you go lateral, which I don't think is a huge role in the fractional curve? You can usually get to 4-5, but not usually 5-1. So just have an understanding of what your options are relative to the fractional curve before you go into surgery and you go execute it. Then the second thing you look at is the main cob. And how you fix that really is dependent on what you did to the fractional curve and what the bow classification is, so that you understand how much you need to fix it to put the head back on top of the pelvis. And don't be afraid of leaving patients with a curve. They don't care about that. Again, they care more that you're getting them realigned. I would say more commonly, these just need posterior releases. A lot of times they don't need anything from an inner body standpoint. Once you release the spine enough, you're able to position those bones in space. You can use things like TLIFs like we saw today as well. You can use laterals up here. It's usually this portion of the lumbar spine is very accessible from the lateral approach. Or if you want to go old school, you can do the shark bite A-lifts all the way up. This is a surgery that we had planned. This is what my fellow's steps were for the coronal plane. Just to show you, this is her slide. So it's not just something that we talk about, something we make our fellows do, and we think through the different scenarios of how to get the spine into an appropriate alignment. Understand that you can use things like a kickstand to help with the alignment, and here this patient is at her 1 year post-op, having achieved a good coronal and sagittal realignment. So again, be methodical is the key here. Understand the bow types. This one's a bow A, but is in danger of being a C, because if you fix the main lumbar curve too much, you'll knock them off to the right. Understand where the fractional curve is. Understand where the main lumbar curve is, which is the one above it. Understand its magnitude and how you're going to try to go correct it. And then you can work your way through this case. We did an A-lift at the bottom. Here's the rods that we had designed for her. And then we put the rod on the convex side first. And the reason we did this is because if you're going to compress on one side first, you want to do it on the convexity to help with the coronal curve. But I would also say really important to apply compression before distraction, because you want to create lordosis, not reduce it. So applying compression is critical. Having both rods then in place, you can see here that our fractional curve is still off, right? You can see that the L4 screw on the left is higher than the one on the right, and that the distance between L4 and 5 is still different on the right versus left. So we'll apply some compression on the left side here first, and try to bring that fractional curve over to the left a bit more. On the right side, we'll then do the distraction like you see here, which will hopefully, again, deliver the L4 into more parallel alignment. You can then radiographically assess that. So this is what an intraop fluoro film looks like. And you can see that we're able to get that L4 to S1 segment pretty darn parallel. And then the rest of it ends up just being a cantilever, getting the spine translated back into a straight alignment. So that's the basic technique that we use. We'll use a thing called a T-square in the operating room to make sure that we have our appropriate alignment. Here's our goals with our T-square, trying to get that back into place, implants and bone graft in, and post-operative assessment. And so here, still off to the right a little bit. Don't love that, but satisfactory. All right, so now we're going to shift over to the sagittal plane. Sorry, it's a big mouthful. We're about to get another dose of data here. So first thing we're going to do on the sagittal plane is try to determine the shape. And to do this, well, I'll talk about it in a second. So the second we're going to do is figure out our angular targets. Those are segmental, regional, and global. And then the third is figure out our release strategy. And then fourth, go execute it. Fourth, just remember your coronal plane, the previous 10 minutes that we just talked about. And then finally, we're going to go execute our plan. So I always say don't remember the coronal plane because none of these targets happen in isolation, right? The spine's a three-dimensional structure, so just be aware of that. So again, shape matters. Rusli did a really nice job of explaining this for us. He described the spine in 4 different types. What I would venture to say, though, is you kind of want to think of this more as a gradation from low PI to high PI, and it's not black and white, right? It's definitely a gradation from one to the next. Bertha Nod did an amazing job of helping us understand where we should be creating our lordosis and kyphosis. And this is a really, really important paper. If you haven't read it, I highly recommend that you read it. It's from the mid-2000s, but it helps you understand the idea that you're trying to create here. Probably one thing I'll just drive home real quick. If you look at the upper arc of lordosis, so it's the one that's labeled upper arch of LL. It's the same exact number as your thoracic kyphosis for the lower arc of the TK. These numbers you will have these numbers work out. And if you fuse a patient with disharmony between those two, you're simply pushing the kyphosis to a different level, like we saw in that last case. So when you overcorrect something, it will find a way to try to neutralize. And unfortunately, when we get the shape wrong, it can lead to things like PJK and mechanical failures a lot more often. So highly recommend reading this article. It's a bit overwhelming to see on a slide, but I think it's worthwhile to drive home for those of you in training. Rusli ones have a low apex, usually around L5. And their lower arc is really low of their lordosis, and their upper arc of their lordosis to L3. So if you're measuring L1 to S1 in this patient population, it's meaningless because they're between L1 and L3, they're already getting kyphotic. So they will have a mismatch. But it's supposed to have one. It's normal to have one in this patient group. So be aware of these patients. And if you flatten them in surgery, it's a real problem because they will keep failing on you all the way up the spine. The Rusli 2s, there are inflection points a little bit higher between the kyphosis and lordosis, but their apex of lordosis is a little bit lower still at L4. And their thoracolumbar spine is actually pretty darn flat, and they stay pretty flat all the way up. And these patients, you want to be weary of overcorrecting their lordosis because you can create a different kind of shape, and typically you'll create an R3 or something like that. So with the Rusli 3s, the lower arc of lordosis is between 3 to 1, and their upper arc is usually between T12 or L1 to L3. So this is kind of that classic L1 to S1 group where you measure the lordosis. This usually works out pretty well in these. The main danger in reconstructing them is that we create a false type 2, where you create a patient that does not have enough lordosis at the bottom. And then these patients will then extend their thoracic spine to try to maintain their upright posture. And while they may see some improvements from their surgeries, they, in the long run, are not so happy because of all the work they have to do to stand upright. And the 4s are a little bit more atypical. We don't see these that often, but they have a very long sweeping lordosis. Their lordosis can end up at T10 T11. And then they have a much higher apex of their kyphosis going up there. And the same risk here is creating false type 2s. This is kind of what we taught historically, but I would say now we know as a dramatic oversimplification, and we should probably remove most of these parameters from our daily view of deformity and move on from it. It has been important in our world because it's helped us classify patients a bit more. But I think we're realizing now that classifications are probably harmful rather than helpful. When we realize that patients' spinal alignment is a lot more on a gradation than it is being able to clump them into a bucket of similar patients. And here's this idea of PILL being an actual problem, right? So if you look at these shapes, those shapes are dramatically different, but they all have a lordosis of 50 degrees, right? And if their PI is 50, then theoretically all of them are perfectly aligned, right? They all have a PILL of 0, which is your goal. But that's a problem because if you look at their shapes, they're going to be dramatically different. If we extend that to what their heads will look like above that, some will have a really high SVA and others will be perfect. So just recognize that PILL is probably not a parameter that we should be using on the routine to, or I should say in isolation. It still has good context, but we should not think of it as the sole way of fixing these patients. The GAP score came out, really important study. If you haven't read this, I think it's really important. This takes into account the mismatch, but also relative lordosis, pelvic retroversion, the distribution of the lordosis, and then an overall true sagittal malalignment, and it puts it together into a score. It adds aging to it as well, and it eventually gets you to a place where you'll have a better understanding not better saying, but you'll have a better prediction of mechanical failure. So the next 5 to 10 minutes are gonna be a little bit of this. It'll be a little bit. I hope I don't blow minds too much. Maybe not, maybe in a negative context, but here's the cheat sheet. So if you're gonna take something home today, like maybe take a screenshot of this. This is sort of the latest and greatest of what we know, and is actually pretty easy to measure on most of our patients. But I would say this is kind of what you wanna take home today. 4-to-1. If we look at normative data, L4 to S1 is fairly consistently 40 degrees around there, and it's agnostic of your PI. So your PI can be 80, your PI can be 30. You still need about 40 degrees from L4 to S1. I do make this one point, which is here's a patient that came in. The L4 to S1 was 18 degrees, but I had him go back and get his MRI from, this is 2011, and his L4 to S1 was 47. It's still within the normative range, but had I reconstructed him to 38, I would have been very short on what he actually required. So whenever you can get the X-rays or MRIs from years ago, it'll really, really help you. If you haven't read this paper, another really important paper, it really defines normal alignment. We don't have anything else like it. This is normal alignment in normal humans, not in deformed patients or asymptomatic deformed patients. These are in normal people. And in normal people, the R square for an L1 PA, the L1 pelvic angle, which is middle of the sacrum to the femoral heads to L1, very simple angle to measure. And you can measure it in the operating room and on every clinic visit, is R square of 0.6, which is really high in a biological model that has so much variability. So really, really good. And furthermore, its correlation to the exact same angle except up to T4 is really, really high. So if you look at the normative population, people want their T4 and L1 PA to be normal. And in order to get there, it kind of dictates what shape you create. So to get that number, what normal should be for an L1 PA, we're able to define it through this normative paper as 50% of your pelvic incidence minus about 20. And then you want the mismatch between T4 and L1 to almost always be 0. And if you get that right, you'll see that your mechanical complications are actually reduced. So we took this to the next level and said, how's this look in the deformed spine? So we took this up to the ISSG and we said, we probably have lower mechanical failure, better balance, and improved patient-reported outcomes. And so we looked at 276 patients, and you use reoperation as our primary variable. We looked at our ability to achieve ideal PA, and then what the T4 L1 mismatch was relative to that. And here's what we found. Basically, when you're on target, your risk goes down to about 10%, meaning that there's other factors that come into play with the alignment. However, if your alignment is good, if your L1PA is at target and your T4 is equivalent to your L1, then that provides you with the lowest risk of having a mechanical failure. So really, really critical, where we've finally been able to quantify something a lot more specific to our patients. So again, about half of PI minus 20 is the main thing to take away. And then your mismatch should be about 0. Another good, just 0 is kind of the easiest way to remember that. Then there's the C2PA. So it's that same PA angle. So these are just pelvic, these are just vertebral angles that go to the pelvis and to S1. So you can take that L1PA, just move it to T4, and then this one you just move to C2 to see what that's like. And that's really is a true measure of global alignment. And we understand here that C2PA and C2 and the pelvic tilt are actually very highly correlated in normal patients. So this is really good because we can extrapolate things from that. And we actually understand now that these 3 parameters are very intimately involved with one another. So when you look at the change in the C2 pelvic angle, it actually mirrors the change in the T4 pelvic angle. So we know that if you get that T4-L1 relationship right, the global alignment, the C2, will also highly likely follow suit unless they have a cervical deformity. We also know that if we get patients into the appropriate alignment, that they'll be in a lot better shape. And then the worse these measures are, so the higher, in this case, the C2 tilt is, which is the C2 tilt is simply a vertical line, a gravity line relative to C2 to the pelvis. So the more forward that is, right, it's a much better measurement than, say, SVA. The more forward that is, the worse off patients are. And so, like, we're trying to, again, try to get these patients back into as normal alignment as possible. This is the paper I referenced of when to stop at upper thoracic versus lower thoracic. And you can see as the C2 to T9 angle increases, as those vertebral angles increase, the risk for PJK actually goes up dramatically. So if you have a patient that has a very high offset between C2 and T9, you want to reconsider the stopping point, or at least counsel the patient. Like, nothing's ever going to be 0, but you can at least counsel them that, yes, we may save levels, but the chance of being another surgery is relatively high. And this is what those angles look like. The red is on the T9 and then the orange to C2, and that's the angle that we're measuring in between those. So know how you're going to release the spine. I think if you're doing type 1s, type 1s and 2s, you're really trying to create a lot more your lordosis low. But with type 1s, you're going to start really with a long kyphosis. Around L3, you're going to start building kyphosis into that rod, and that kyphosis extends all the way to the end of your construct. And type 2s, you're going to make that kind of the opposite. You're going to make that actually relatively straight. So understanding what the shape is will really very much change on how you end up bending the rod. And then the 3s and 4s require a much longer sweeping lordosis with a longer sweeping kyphosis. So those are the more classically S-shaped spines that we think of. Know your osteotomies. I know you guys like to do the IDOs. Those are very powerful. Schwab put the classification in place for how to release the spine. Just know what you're able to accomplish, know what your limitations are, and then I would say as you go into practice, know what your institutional limits are. If your institution won't tolerate doing PSOs, well, then don't do PSOs. There's nuances to the osteotomies, making sure you have disc spaces where you can get releases. And then I would say don't totally buy what the literature says that you can get 5 or 10 degrees. Like, you need to release the spine so that then you can reshape the spine to what their anatomy is. So know what you're trying to accomplish segmentally, regionally, and globally, and then figure out what shape you're trying to create, and then be able to execute on it. Just a quick little demonstration of that. Here's that case we showed earlier, where we have non-unions at the bottom, have a plump disc space at L4-5. And you can see here we have a big vacuum disc at L5S1 where the non-union is. In these cases, you can do a realignment as such with a simple T-lip at the bottom and a posterior column osteotomy at L4-5. And we got the alignment back to that 47 or 48 degrees like you had previously, and we get a good realignment like you see here. So I think I'm out of time. So on that note, I will stop. I see I have time for one more case. I can show you one that's a little bit decompensated.
Sure. Fire away the last case. This is such an amazing lecture. So let's conclude with the last case.
Awesome. So this is a bow B. So the patient's offset. He's offset towards the side of his concavity. His head is tilted forward. So if you look here, his C2 pelvic angle is high, right? His T2 to T9 is high. His T4 L1 mismatch is high. So this patient needs sort of a realignment in numerous planes. And you can plan this out if you use some surgeon-specific rods. You can say, hey, I need some osteotomies down low. I need an osteotomy up high. This is what he would look like if you neutralized his C2 tilt, right? We put the C2 tilt to 0, and that's what he looks like. And then go and execute it. We had the pre-bent rods, and this is kind of what we did in the operating room. And you can notice here, if you measure them in the OR, this one actually has an LPA of 9, and our goal was like 4. So we were short. I love this example because it's actually something that you can change. We took the rod out, we rebent it, made it into a better shape, and then put it back in. And then now you can see that pre to post. Here's the intra-op films after reassessing where we were. And here she is at her 1-year post-op, having a good neutral realignment of her kyphic scoliosis. So, awesome. Thanks, guys.
Fantastic. So I think you predicted one question by Dr. Yoshi with all this parameter planning being more sophisticated and insightful pre-contoured rods. You kind of preempted that question already. Is this a routine application for you nowadays, pre-contoured rods, or do you still craft them as you see fit?
So I'm sad that I don't craft them as often as I'd like. I love crafting the rods. It's like my favorite part of the surgery. But I will say, being able to plan the operation to what I want it to be, then the rod itself actually ends up being a much more reliable way of reconstructing the spine. I think if you don't want to use the pre-contoured rod, I think the plan is the most important. And if you're able to show the shape of the rod that you're trying to create, I think having that shape with you in the OR is probably maybe all you need. The nice thing about having it manufactured for you is that it really does get quite specific on exactly where the inflection points are and exactly what the shape is that you're trying to recreate. And it gives you a good template in the OR to know if you've tried to accomplish what you were setting out to do. So I use them almost exclusively now.
And so much wisdom in there, so many questions. Just one quick question, actually two. One is dynamic x-rays. Do we still need left-right bending films? Are they of any value in adult patients? I know we get them in kids more, but is that of value in your planning?
I do not get bending x-rays anymore, the left and rights for adults. I do flexibility films. Just want to see what happens when they relax. So I think, again, we can use the scouts from the CT. Or you can actually get a supine image. We do both. But that's about all the flexibility films I'll do. On the AIS patients, like the 30-year-olds or whatever, I do still get them on there because sometimes LIV selection or trying to do selective thoracic is important for those. So, but like once you're in your 50s and 60s, it usually changes.
I'm going to hit two questions with one. I'll integrate them. You mentioned something that surprised me, that is you get supine lateral full-length films and then standing laterals to assess the global dynamic things. I take it these are plain films and not just the opportunistic scout films from the CT scanner. Is that correct?
Correct.
So this is the question. This subject of undercorrecting older patients, is this real or not? So we showed a case of Dr. Skurians with that 80-year-old lady, and you did not like the shape of the spine. How does this apply nowadays? Was this really a helpful modification of our alignment goals to undercorrect older patients, or how do you put that into action?
I don't believe in age-adjusted data. So I think patients want to be upright and relaxed if they are mobile. If you have patients that are immobile and that want to sit for 15 hours a day, do not give them a bunch of lordosis because they will be super unhappy sitting all day. So they should probably not have surgery to begin with, that kind of surgery, but like, because you're really trying to fight for mobility. But patients that aren't walking, they are more comfortable with a flatter spine.
So here's so many more questions, such a treasure trove of insights and information and open discussion points. So thank you, Greg. Happy holidays, Merry Christmas for all of you and who want to celebrate that. And don't forget tonight, 5:15, a very unusual presentation on venture capital and its beneficial role for medical technologies. But Greg, thank you so much. Have a great day.
Thanks, guys.